Hello everyone. A 45-year-old man come to you, right flank pain the problem. He's tossing in the bed from pain and abdominal radiograph shows no abnormality, but CT scan shows 5 millimeter stone in the right ureteric and several small stone in both renal pelvises. Urine analysis pH 4.5, normal is 5 to 6. It is acidic pH. WBC is absent, but RBC is plenty. Rest all are normal. Patient subsequently passes a stone and analysis show that it is a composed of 100% uric acid. Despite high fluid intake, which of the following is the most helpful for prevent recurrent stones? Well, before we go, lovely picture of different type of stone: calcium based stones, steroid stone, which are mainly phosphate stones, uric acid stone, and cystine stones. Well, the answer to this question is potassium citrate. There are three likely possibilities when a patient has symptom consistent with typical renal colic, but no stones are identified on conventional radiograph. Remember, in this case also, abdominal radiograph show no abnormality. Well, history is typically of suggesting of renal stone, but X-ray is normal. So now, three possibilities. Radiolucent stones, like uric acid stone and xanthine stone. Like in this case, it was confirmed that when the patient passed the stone, it was of uric acid. Calcium stone, but size is too small, less than 1 or 3 millimeter. They are likely to be missed by conventional radiograph. Non-stone ureteral obstruction like blood clot or tumor. So three possibilities where this X-ray may be normal. Well, patient has a uric acid stone which account for approximately 10 to 15% of nephrolithiasis. Patient subsequently passes a stone analysis shows it was a uric acid stone. They are more common in patients with usually low urine pH, In this patient, urine pH is 4.5, normal is 5.6, so it is a acidic urine. This may be defect in renal ammonia excretion or hyperuricemia. There are two possibilities, either defective ammonia excretion or maybe hyperuricemia. Uric acid stone are radiolucent as informed earlier, but can often be seen on renal ultrasound or CT scan. Even our case, abdominal radiograph showed no abnormality, but CT scan shows a 5 millimeter stone in the right ureteric and several small stones in both renal pelvises. Treatment of uric acid include hydration, alkalinization of the urine, and low purine diet. So, when we do alkali, urine pH to 6 or 6.5, like with oral sodium citrate, uric acid stone are highly soluble in alkaline pH. Hence, this is the best answer. In addition to alkalizing, the urine citrate is a strong inhibitor and reduces crystallization also. Allopurinol can be added if there are recurrent symptoms despite initial behavior, especially if hyperuricemia is there. In case uric acid hyperuricosuria or hyperuricemia, that means in such cases we like to add allopurinol, which will lead to reduce uric acid synthesis. Let's look into other option: calcium restricted salt. Calcium restricted salt does not have no beneficial in the management of uric acid stones. It's not advised even in patients with calcium stone also, as calcium restriction can potentially cause negative calcium balance in the body, hyperoxaluria due to resulting increased GIT absorption of oxalate. There are two possibilities which can happen if the calcium is restricted from the diet. Furosemide increases urinary calcium excretion. Hypercalciuria can increase risk of increased calcium stone formation. Furosemide is used in the treatment of hypercalcemia, especially acute hypercalcemia. Okay. High protein diet, purine restriction not high protein diet is indicated in patients with uric acid stone secondary to hyperuricemia or hyperuricosuriia. Hydrochlorothiazide, this decreases urine calcium excretion, is used in the management of recurrent hypercalciuric renal stone. Golden line to remember, uric acid stone are often radiolucent but may be seen on ultrasound or CT scan. They are highly soluble in alkaline urine. Alkalination of the urine, pH 6.6, oral sodium citrate is the treatment of choice in such cases. Thank you very much.